grateful to the Unitarian Church for the use of this beautiful sanctuary. And so, let me get started. My name is Kay Tillow. I have the privilege of being the chair of Kentuckians for Single-Payer Healthcare, and we are the sponsors of tonight's meeting. I'd like to introduce to you Dr. Karen Krieger. She is, glasses back, a professor at the Department of Family and Geriatric Medicine. She is the director of Health Equity Health Sciences Campus at the University of Louisville School of Medicine. She's the immediate past co-director of the Southeast Division of the American Association of HIV Medicine. She is a true Louisvillian. She received her Bachelor of Arts and her Master of Education and her medical doctorate degrees here at the University of Louisville. She taught in secondary schools in Jefferson County Public System for 8 years before going on to join the faculty of the University of Louisville Department of Family and Geriatric Medicine. She started the HIV clinic here. It's the third Ryan White HIV clinic in the state. And she has many other credentials and professional talent. But I think we know her best for the work that she does in our community. She takes the students that she works with to go into the communities where there is not enough care to do screenings for diabetes and breast cancer and HIV and all of those things, trying to bridge the gap between a broken healthcare system and to bring care to the people who don't have it. So she is a community treasure, and I'd like for you to hear from her to start our program. Dr. Karen Krieger.
Thank you so very much for letting me be part of this event. The people working for Single Payer here in Louisville have worked diligently for a number of years, and I've been very proud to be part of their association whenever I can. I'm a primary care provider first, an HIV provider second. To me, HIV is primary care with a twist. But I can tell you, I look at our system, and I used to think when I was a young resident and a very young faculty, that everyone that I took care of one day would have everything they needed to stay healthy. I thought we were almost there with Obamacare. I had patients we were holding together with scotch tape and baling wire, waiting for access. People that were working jobs, taking care of families with horrendous blood pressures, who were putting off visits because of huge deductibles now. People who are just now being employed and are very pleased to have insurance, only to find out that what they have gotten from their employer is basically catastrophic insurance. Paying for one physical exam a year and one acute visit. And if you discover a chronic illness like hypertension or diabetes or hyperlipidemia, increased cholesterol, or obesity, that's not accounted for until you pay your $5,000 in your deductible pot. And these people, of course, they chose the cheapest plan because they're making minimum wage. And their co-pays prevent them from coming in for care. So as a nation, we're really good at transplanting any organ you need or any joint that you need. But we're not very good at providing prevention because it's a lot cheaper to take care of things on the front end than the back end. If you go to the emergency room to sign your name on a piece of paper, that's $300, whether they give you a glass of water to drink or not. We need to make primary care, prevention care, accessible to all so that we don't have one of the highest, I think we do have the highest expenditures for medicine in this world. Of all the developed nations, we have the worst health outcomes, the shortest life expectancies. Can you believe that of us? Because here, medicine is a commercial commodity. Its goal is to make money from illness. We need a goal to make our country healthy, to make our citizens healthy. A chain is only as strong as its weakest link.
Yeah.
And if we have weak links in our chain, we're not going to compete globally with what's out there. I've been out there in other countries, and it's amazing that refugees come into this country and they have a hard time navigating our healthcare system. Because Germany or England or Italy, they get sick, they go and they're cared for. Here, not so much. So I'm really pleased to be able to listen to Dr. Friedman. He's bringing us an alternative model to a broken system. And we all have a chance to vote. We all have a chance to make a difference in what our lives are going to be like. Thank you.
Thank you, Dr. Krieger. And now I'd like to introduce the person who is most responsible for these events and the invitation to Dr. Friedman, and who is the founder of the Physicians for a National Health Program in Kentucky. And he is the past president of the national organization. That's Physicians for a National Health Program. That is the group that has set forward a single-payer plan without profits that would be an improved Medicare for all. The person I'm introducing is Dr. Gerald Adams. He is a pediatrician. He has worked for decades in this city, bringing care to the children of our region. He's a specialist in infectious diseases and teaching at the University of Louisville Medical School. And I've had the honor to work with him for a couple of decades now on this project. Dr. Gerald Adams.
Thank you very much, Kay. It's a wonderful group. I wish you could see yourselves. We're thrilled to have this group here tonight. And we are so excited to have the man of the hour in the United States here in this church tonight. Everybody wants to know, well, what about Medicare? Medicare for all. What is it? What really is it? And then you talk about it a little bit and say, well, how are we going to pay for it? Two big questions, and Dr. Friedman has the answer. This is the man, this is the guru. This is Professor Gerald Friedman, and his bio is here. He has impeccable academic credentials. He's sought after all over the country. The candidates that are calling him for answers on both sides because he has them, and they know they can believe what Jerry says. So not only this, but it's been a wonderful pleasure to get to know this man. He's a lot of fun. I think his favorite companion is his dog Corduroy. And Corduroy comes to the classes that he teaches 783 students in a microeconomics class, and Jerry walks around and takes care of all of that. And he's a marvelous human being that you will now get to know, Professor Gerald Friedman.
Is this on? Okay, thank you. Garrett, thank you. That was way too generous. Although, if you knew my dog Corduroy, you know that every kind word everybody says about him is true. Total sweetie. I thank you all for being here, and thank everyone for having me. I've been in Louisville since, what, Tuesday? It's been great. My wife asked me, are they giving you Southern hospitality? I said, yes, yes, it's wonderful. Okay, today we're going to talk about improved Medicare for all, and here's where we're going. I'm going to start with talking about problems of U.S. healthcare. You already heard we have a very expensive healthcare system. It's worse than you may have been led to believe. And then we're going to talk about how some economists think about healthcare and how they have made things worse, because one of my all-time favorite things in life is to dump on the economics profession. And then improved Medicare for all is the solution, and we can do it. And it's really the only solution. I mean, there may be steps along the way, we may make some compromises between here and there, but we gotta get there. The alternatives are unacceptable. Okay, starting with U.S. healthcare. I'll give you some basic ideas here. And I always tell people that if you get nothing else from anything I say, try to remember this graph. And if anybody wants it, or the rest of my PowerPoint, just write to me, I'll send it all to you. Okay, this graph gives life expectancy over here, and the logarithm of expenditures along here for member states, member countries in the Organization of Economic Cooperation, the club of the rich, as we used to call it in graduate school. And forget this one for a moment. When you look along here, what happens to a country's life expectancy when you spend more money per person on health care? Yes, thank you. I mean, this should not be a surprise. Yet I can assure you that in 1982, I took part in a seminar at Harvard, and two very, very prominent economists came in at different times and said that healthcare spending has nothing to do with life expectancy or well-being. People go to the doctor as a consumer activity like skiing. Richard Zeckhauser, at that time, was in between stints in Washington as healthcare advisor to Nixon, Carter, Reagan, and Clinton. And he was head of the Kennedy School of Government. And Martin Feldstein, who was on his way down to Washington to be head of the Council of Economic Advisors. And they both said this. Zeckhauser said something even worse, by the way. Misogyny is not new in American politics with the current occupant of the White House. Zeckhauser said, when grandma feels lonely, she goes to the doctor to have somebody to talk to. Otherwise, healthcare is like going skiing. That was an example he used. You want to go skiing, you pay for it. The problem with healthcare, he said, is that you're not paying for it yourself. Your insurance company pays for it. So people abuse. That's the word he used, Feldstein used, and other people, other economists use. People abuse healthcare. They use too much of it because it's really just a waste. Well, guess what? They're wrong. It should be nothing surprising that economists are wrong. They are most of the time. At least economists outside UMass Amherst. They're wrong. You spend more on health care, people go to the doctor more, they live longer, they're healthier. You know who lives the longest? The Japanese, who are kind of over here. They do especially well. They go to the doctor 12 times a year on average. We go 4 times a year. And then you get to the United States. So here, okay, you do have to make excuses for Zeckhauser, Feldstein, and all the other economists, because they're thinking about the United States. And you notice? In the United States, we spend a lot on healthcare. We spend, remember these logarithms, that we spend 50% more on healthcare than does any other country. We spend about twice the average of the OECD members. Yet, we have relatively poor health outcomes. We're spending all this money, but we aren't getting the health care. So when they say spending money on health care doesn't help, yeah, they're thinking of the United States. They're not thinking of the rest of the world. In fact, our life expectancy, if we were like everybody else, we would live 6 years longer. Given what we spend, we should have 6 more years of life. Or, we say, okay, we'll settle for the life expectancy we have, but we want our money back. $7,000 back. Now, $7,000 per year. At this point, they usually ask people, you want the money, you want the life? Those my age will say, we want the years. Sarah and Lucy and the other young people in the audience thinking about paying for college or paying their college debt might say, I'll take the money, please. But whatever it is, we're getting screwed. What's more, it's getting worse. Our healthcare expenditures are rising. We're spending more and more and more, and it's taking money out of the economy. People don't have money for cars. They don't have money for solar panels on their houses. They don't have money for vacations. They work longer hours. I'm not even talking about how they don't have money for medications. I'm coming to that. They don't have money for food. Every major consumer activity has had a reduction in spending over the last 20 years because we're spending so much more on health care. And it's gotten worse. Jumping ahead just slightly, it's gotten worse since 1971 when we began our experiment in for-profit medicine under the Nixon administration. The last president to be thrown out of office. I like thinking about that. American workers haven't had a raise. Well, businesses will turn to them and say, I've been in these labor negotiations as a consultant. Businesses will say, well, we're spending all this money on you. Yeah, because where's the money going? It's going to health care premiums, health insurance premiums. Businesses are spending money on workers. The workers aren't getting it in wages because it's being siphoned off by the vampire health insurance industry. And for all that, we're getting worse. Back as recently as the mid-1990s, our life expectancy was about the average for members of the OECD. But now, we're 1.5 years short. We've lost that much ground in 20 years. Everybody else is moving along nicely, thank you very much. Everybody else who has universal health care is moving along nicely. Canada has widened the gap. They were living longer than us 40 years ago, and now they're living 3 years longer than us. They look across the border and they snicker. You know what they call their universal single-payer health care system? Medicare. Just to tease us. They say, we've got the real thing. What you guys got. No, we wouldn't settle for that in Canada. And they shouldn't. Here's physician consultations per person. Average countries in the OECD, over 6. The United States, 4. As I mentioned, the country with the longest life expectancy, Japan, 12. Don't tell me going to the doctor is a waste. It's a waste only if you don't care how long you're going to live. Well, this is the product of 40 years of healthcare innovations, of healthcare finance innovations. We raised copays. You know, 25 years ago, the federal government's survey of health insurance plans didn't even ask what the average copay in a plan was. They didn't ask what the deductible was. 30 years ago, 25 years ago, these were so small as to be insignificant. Now, all this detailed data about the type of plan, the copays for this, the copays for that, the complexity of the survey form has increased. You can imagine, you don't have to imagine, you all experience it, what's happened to the complexity of your insurance booklet, where they tell you about your insurance plan. You know, and we've done all this, and now a third of Americans report in a Commonwealth Fund survey that they could not do some healthcare activity. They could not go to the doctor, they could not fill a prescription, they could not go to a specialist because of cost. By contrast, for the rest of the OECD, 13%. That 20-point gap is the product of treating healthcare as a commodity. And what results from that is here. People die. Every diamond here represents a county in the United States. And on the vertical axis, you have the age-adjusted mortality. The horizontal axis is the proportion who reported that they cannot afford to go to the doctor because of cost. What happens to the death rate in a county when more people can't afford to go to the doctor? More people die. This will be on the final exam. Only an economist would be surprised. Yeah, people don't go to the doctor for recreation. If I want to go for recreation, I walk corduroy. I go to the doctor because something hurts, or something's lumpy, or whatever. You know, I have a problem. And I know well enough that while I have a PhD and you may call me doctor if you want, I'm not a physician. I'm not going to self-diagnose. Even if I was a physician, I wouldn't self-diagnose. You need to go to somebody else. You know, people who don't. People who, you know, have more income, better health insurance, don't worry about the cost, they live. And this is a big deal. I mean, this represents hundreds of thousands of extra deaths in the United States. As much as 10% of U.S. mortality can be explained by this one variable, whether people can go to a doctor. Kentucky, same thing. Almost exactly the same regression line. Counties in Kentucky, and you've got a lot of them. Yeah, about 95. Oh, 120? Oh, God, I misheard. 120, oh my God, yeah. Okay, 120 in a state of 4 million people. That sounds interesting. But maybe they expected to have more people when they set up the counties. Yeah. Okay, but anyway, you've got 120 counties, and those with the highest proportion who cannot afford to go to a doctor, these data, by the way, from 2012, before the implementation of the Affordable Care Act, which has done so much in Kentucky and elsewhere to improve health care access. Counties where more people can't afford to see a doctor, higher mortality. Yeah. Not everybody's suffering like this. Years ago, my wife poured out her pocketbook, lined up her health insurance cards. We get one every year, even though we haven't changed our plan since 1991. But she lined up her cards, there are about 10 of them. And she said, Jerry, Do you realize what's been happening to our copay? You know, I'm a fairly well-paid, full professor. We don't pay attention to these things. We're lucky, we don't have to. But you line them up and you realize how much we're now paying to go to the doctor? So, a few days later, of course, I had a scratchy throat. I thought about it. I told her I'm thinking of going to the doctor to check whether it's a strep. And she said, well, you realize it's going to cost us X amount. And I said, honey, it's okay. We can pay it. Well, not everybody can. We're over here. And life expectancy has increased for the more affluent Americans. Over here, we've got ranking the poorest 10% up to the richest 10%. The vertical axis is the change in life expectancy over the last 20 years for men in blue and women in orange. The richest people are living longer. And for these people, in the top 20% of the American income distribution, life expectancy is comparable to what you'll get in other affluent countries. Not better, by the way. Only about average for other affluent countries. But as you move along to poorer and poorer Americans, male life expectancy is leveling off. It hasn't been increasing as much, but at least it's been increasing. Look what's been happening to female life expectancy. For the poorest 40% of Americans, life expectancy has been falling for women. For the poorest 40% of American women, life expectancy has been falling. The first time I presented this, it was years ago in Oregon, and I expressed bewilderment. How on earth could this be happening? Afterwards, and I love these talks because people are always teaching me things. And afterwards, a woman came up to me and said, oh, there's no problem, I understand it. I work in a food bank, and I see it every day. Women show up at the food bank, they can get enough food for their children, and they feed the children. I mean, no mother, and not very many fathers, would eat while their children are hungry. Who's going to get the prescription filled? Mom or the kids? If you have only enough money for one prescription to fill the kid's prescription, of course. So what this is telling us is these mothers are canaries in the coal mine. Women who are dying because of rising inequality in income distribution, so families don't have enough money for everybody, and the rising cost of health care when we treat health care as a consumer good rather than a human right. These women are dying because of copays, deductibles, and of course, poverty. Okay, healthcare finance interferes with providing care, and it's been getting worse with what I call the market turn. Market turn is kind of a generic phrase that economists use to describe the change in economic policy in the United States, in Britain, and in many other countries to reliance on the market, treating things as commodities rather than treating them as social rights. And that certainly has happened in healthcare in the United States. U.S. healthcare is becoming more expensive. We were about average in 1971. Technically, a lot of people say, well, Americans are having poor life expectancy because we eat too much, we're fat. Yeah, that's true. I had to get a new suit after 15 years. I kind of outgrew the old one, and I'm not getting taller. It's the other dimension. Yeah. But, there are a lot of things Americans do that are really good. We smoke a lot less than people in other countries. My wife would complain that walking down the streets in Paris, people are waving their cigarettes around, and you gotta be careful that you don't get burned by them. We drive much better, our roads are safer. Only the Canadians, the Australians, the New Zealanders, and the British have safer roads. I don't understand the British. There's narrow, winding roads, and they drive on the wrong side. I do not understand why they don't kill each other all the time. But, okay, we are actually safer And our life activities are healthier than most other countries. Plus, while we are fat, other countries are getting fatter faster. So we're losing our advantage in obesity. Hey, this country, nothing's working. You know, this gives you a sense of where we're at. Horizontal axis is change in spending per person, adjusted for inflation. Vertical axis, change in life expectancy. You know, we just suck. You know, it's like we're spending more and more. Our horizontal line is the longest, but we have the flattest curve. You know, so we're getting the least for the most. You can actually take these numbers and estimate how much more would we have to spend to catch up to the life expectancy of the average OECD country. The answer is about $6,000 more. So we're spending about $10,000 per person. We'd have to go to like $16,000 per person to catch up, given how inefficient our healthcare system is. How some economists think about health and how they make things worse. Economists think what we need is skin in the game. You've heard the phrase? Yeah. Yeah, people need to be paying for their health care or else they'll waste it. We should encourage competition because that will bring down costs. You know, people tell me, people have said this to me. Well, the way we increased efficiency in the auto industry was by letting the Japanese sell cars here. Competition is good. Well, not in health insurance. Healthcare is not a commodity like any other. You know, one of my teachers in grad school, Kenneth Arrow, wrote a very famous article on this. He won the Nobel Prize in economics. This article is one of the most widely cited pieces in economics. He's one of the smartest people I know. Does anybody read the article before they cite it? I don't think very many people do. Because if they did, they would understand. Healthcare is not a commodity like others. If you treat healthcare like a commodity, you're going to be screwed. And that's what's been happening. So, we regulate the doctors to stop them from over-treating, because after all, healthcare is mostly wasted. We regulate consumers to not let them use doctors, because it's mostly waste anyway. And there's no real danger if we reduce utilization. So we should promote consumer cost sharing. Oh my God, how I hate that term, consumer. When I go to the doctor, are you a consumer? You're a patient. You know, the physicians here, when you see people, are they consumers? I'm a consumer when I go skiing in Smuggler's Notch, Vermont. I'm a consumer when I buy onion rings from, you know, that place where I buy onion rings from in Amherstown. When I go to the doctor, I'm a patient. I need care. Okay. How is the use of the markets work? You know what? Not only does it kill people, but it makes costs rise. Insurance company competition does not lead to efficiency. It leads to inefficiency. Insurance companies are not able to regulate the prices charged by providers because competition among insurance companies undermines their ability to stand up to powerful, monopolistic drug companies and hospital networks. And utilization review, even if it lowers spending in the short run, it often makes it worse in the long run by making people sicker. Okay, private insurance is inherently wasteful. There's a rule, and it holds up in most insurance, and it holds up in Medicare. 70% of your costs, you know what they call the costs when an insurance company is talking about costs? They call them medical losses. The money they spend on your health care is a medical loss. They calculate a medical loss ratio, the share of their spending that goes to health care. And they want to make that number lower. The lower it is, the more room for profits. What's the best way to make it low? Well, let people die.
Deny
Deny care? Yes. The best way of all is to not even let these people buy insurance from you. When my father was in the coffee business, he tried to sell more coffee. He tried to make his coffee cheaper and better. He was fairly good at it. My insurance company doesn't want to sell more policies. They don't want people like me who take lots of drugs and have various conditions. They want, with all due respect, Sarah. They call that lemon dropping when they get rid of me. Find those 10% who are going to be expensive, get rid of them, and you can lower your medical losses by as much as 70%. And you can laugh all your way to the bank. And you will get, as the CEO, you will get a raise. Insurance companies often tie CEO compensation to medical loss ratios. Keep the medical loss ratio down. Drive out the lemons and pick the cherries. Sarah's a cherry. I'm a lemon. Why is healthcare expensive in this country? I mean, yeah, part of it is the administrative cost of lemon dropping and cherry picking. But the largest reason why healthcare is expensive in this country is because the price of healthcare. And the biggest single element there are hospitals. And what's been happening in our hospital sector? Take Massachusetts. About 25 years ago, we had Massachusetts General Hospital. It stood alone and beautiful, one of the leading hospitals in the world. Massachusetts General Hospital got together with Beth Israel and Brigham and Women, the other Harvard teaching hospitals, and they formed Partners. Partners now owns about 21 hospitals in Massachusetts, about 25% of the hospital beds in the state, and they charge 4 to 6 times as much. According to a study by the Attorney General of Massachusetts, they charge 4 to 6 times as much for the exact same procedures. Someone told me who ran the emergency department at a hospital in Cambridge, a public hospital, he said that they charge $500 for an MRI at his hospital. Mass General will charge $2,000 for the same MRI. It gets worse. If somebody was hit by a car on Broadway in front of his hospital and taken into his hospital, they take the MRI, they hand the guy the CD of the MRI, and they load him in an ambulance and send him to Mass General. Mass General will throw away the CD and redo the MRI. It will be read, and this is not necessarily true, but it's happens. It will be read by the same radiologist in Bangalore, India, who may wonder, this one looks familiar. I think I saw this the other, an hour ago. Partners now owns a lot of doctor practices. They own my doctor practice. Why? They claim they lose $70,000 for every doctor that they employ. So why do they keep buying them? To steer business to their hospitals. When my doctor sends me to a partner's facility, they're dealing within partners. It's not price competitive. They're not comparing prices. And she tells me that she has a statistic on her work record of the proportion of referrals that she makes outside of partners. And if that number gets too high, then she gets slapped down by her boss. She's a good person. She is making good medical decisions. And sending people to Mass General is not a terrible thing to do to them. But the reason it's being done is to keep the partners' hospital beds full and to maintain profitability for partners, which, mind you, is a non-profit hospital, which means they don't even pay taxes on their profits. So what's happened to hospital prices? For Medicare, they've drifted up. Yeah, Medicare's kept up its rates. But for private health insurance, they've been soaring. As hospitals have formed partnerships and monopolies and taken over physician practices, they have been raising their rates. Now, a private health insurer could say, well, no, we're not going to pay your rates. Yeah, somebody tried that once. James Roosevelt, grandson of the president, the only single-payer supporter in the American Association of Health Insurance Plans. He went to Partners as head of Tufts Health Plan, and he said, we're not going to pay your rates. Within 48 hours, he went hat in hand and surrendered. Because you can't tell people in Massachusetts that your health insurance doesn't cover Partners. Yeah. It's just, everybody was going to drop it. Tufts was going to fail. Partners has everybody over the barrel. They can basically charge whatever they want, and unless the governor or the legislature gets really upset, the health insurance industry can't help. It gets worse. Drug prices. Why do we pay so much for drugs? Nobody else does. Now, the Trump administration says that drug prices in the United States are twice what they are in other countries on average. Twice. That's probably about right. The only agency of the U.S. government to negotiate drug prices, the VA, they get priced about half what everybody else in the United States pays. Why don't the insurance companies fight back? The insurance companies can bargain. Legally, Medicare is not allowed to bargain. Insurance companies can bargain, but it doesn't do any good. You know, they say, oh, well, to bargain effectively, you have to be able to walk away. You can't walk away from drugs. People will die. Some people do walk away from drugs. Well, here's the diabetes slide. The price of diabetes in the United States over here, price of insulin over here. Here's other countries. There are people in the United States with diabetes who try to stretch out their insulin. There are people in the United States with diabetes whose insurance, they have such a high copay or such high deductible that they have insurance, but it doesn't do them any good. So what do? They don't get their insulin. What do you call people who don't fill prescriptions?
Dead?
Dead, thank you, yes, dead. Yeah. Did you come to an earlier talk? You figured it out on your own. Extra credit for her. Yeah. It happens. Remember the slide with all the people dying because they can't afford health care? Diabetics. There's one thing insurance companies are good at, fighting back against doctors. Because doctors are all individualists and they're fragmented. Although they get some market clout when they get bought up by Partners or other hospital networks. But doctors, how do they regulate doctors? They go to the doctors and say, well, if you want to be in our insurance network, you have to give us this price and you have to give us this stuff for pre-authorization, you have to follow these rules, you have to use our medical record system, you have to check all these boxes, you've got to do all these regulations that we have. People complain about government regulations. Have you seen the regulations for the health insurance companies? Regulations designed to make their profits bigger by making your life miserable. And if the doctors turn them down, they get dropped out of the network. And what happens to their patients? What happens to you when your doctor is no longer covered by your insurance plan? Oh, you're just supposed to change doctors. And then the next year, your employer changes insurance plans. And you're supposed to change doctors again. And then they change the network rules and your doctor is back in. You're supposed to change your doctor. I mean, all this disrupts continuity of care. You don't know your doctor doesn't know you. Your medical records disappear somewhere in a black hole. You know, people don't remember what works, what doesn't work for you. They ask you, oh, did you ever try this? Like, I don't remember. patient. I don't remember what. Yeah. I mean, I have a PhD from Harvard. I don't remember. Yeah. Who was going to remember this stuff? Corduroy? Yeah. So people, again, people die. Or they get surprise medical bills. You walk away and say, oh, I thought I was in that work. And, no, it's $10,000. Can you pay today or tomorrow? Yeah. 500,000 Americans go bankrupt every year because of medical bills. Part of it is these surprise bills that come from out-of-network care. So insurers then go after the doctors some more. Tell them, stop practicing medicine. Become an administrator or something. Here are the forms. This is what I have to fill out for physical therapy. You know, I had signed my name 11 times. I brought these forms up to the desk. I said, you know, you, my physical therapist, are employed by partners. My primary care physician is employed by partners. The specialist who saw my foot is employed by partners. Why do I have to fill out the forms? Can't you guys just talk to each other? I said, oh, no, we have separate medical record systems. Yeah. So I said this, I actually was invited to address the Association of the CEOs of Research and Teaching Hospitals. Coconut Grove, Florida. The hotel rooms cost $1,000 each. So $985. I shouldn't exaggerate when the truth is shocking enough. Yeah. So I was debating with Ezekiel Emanuel, who we co-taught the course of social theory at Harvard. Anyway, I told the story afterwards. The head of partners, as you might imagine, was quite pissed at me. He came up and he said, well, that's no longer true. We now have the Epic system, and everybody's on the same system, Epic. Tell doctors about Epic. And they'll tell you about late nights in their pajamas, sitting in bed, filling in the damn boxes for the Epic system. You know how much partners paid for the Epic system? Over $1 billion. And there's a $200 million contract for maintenance every year. And that's just partners. You go out to the Epic headquarters, one of my colleagues at UMass in Comsci consults with Epic. She went out to their campus in Madison, Wisconsin. It's like people will tell you the Midwest has no economic activity. Oh, Epic is rich. I mean, she said the art alone is worth billions. You know, this campus is an amazing place. Somebody's making money on healthcare. It's not physicians. It's certainly not patients. Okay, so this is all the denial management reporting. Improved Medicare for all is the solution. Oh, we seem to have lost our improved Medicare for all line here. No, back? No, okay. Controlling healthcare spend. This line shows you annual expenditures projected by the Center for Medicare and Medicaid Services. People will tell you, oh my God, we can't afford to improve Medicare for all. It's too expensive. You know what's too expensive? A system that in 10 years is going to go from $3.7 trillion up to $6 trillion. Growing almost twice as fast as the economy as a whole. Every year, we're going to be digging into our pockets to find another few $100 billion to pay for rising healthcare prices, the rising price of prescription drugs, rising monopoly prices for hospitals. The one thing we won't be paying for is more healthcare, because we're not expected to get any more healthcare, according to the Center for Medicare and Medicaid Statistics. It's all price increases. Yeah. Now, unfortunately, it doesn't show, but my projections for healthcare expenditures go from here up to there under improved Medicare for all. We save money and we bend the cost curve by controlling drug prices and hospital prices, the elements that are rising fastest in our healthcare budgets. We will bend the cost curve so the rate of increase in healthcare prices in the United States will be more like what they get in Canada, more like what they get in Europe. It will slow the rate of healthcare inflation to about the rate of growth of the economy as a whole, even while covering everybody and eliminating co-pays and deductibles so that people can actually get health care. Here are the savings, 10 years of savings, insurance administration, administration within doctor's offices, prices, this is the biggie, healthcare prices, bringing drug prices down to, actually, I'm not even projecting world levels for drug prices. You know, I'm not even projecting that drug prices will be brought down to what the VA pays. I'm using an old number for this. And bending the cost curve by slowing the rate of inflation will save $2 trillion over 10 years. You know, you look at this, especially if you've got all the colors showing. You look at this, and when people say, how can you afford Medicare for all? Ask them, how can we afford the current system? And if you're saying we can afford the current system, then surely we can afford something that's cheaper. We can work out the details of shifting from premiums to taxes, you know, we can work that out. But the bottom line is we will be spending less as a nation, which means that for most individuals, you can expect that you will be spending less, even while you're getting more care. Here, I'm projecting $182 billion in 2019. It's too late for 2019, but I haven't updated my old numbers. I did these estimates about a year ago. $182 billion in increased utilization by people with health insurance. Almost a 10% increase in utilization by people who are already insured by eliminating co-pays and deductibles. Some people think that number's too high. A few people think it's too low. Those who think it's too low, and this is what lies behind something like you may have read the Urban Institute's attack on Medicare for All. You may have read the McCaddis, these libertarians, who actually found Medicare for All would save money, but they also found very small savings. The way you get that is by assuming there'll be a big increase in utilization. People will be using healthcare a lot more if you do away with co-pays and deductibles. What are they saying? They're saying co-pays and deductibles are so onerous that they are keeping lots and lots of people from using healthcare. They are admitting that the current system is killing them. The Urban Institute is saying that the current system is killing even more people than I say it's killing. And that is the defense of the current system? That is an attack on Medicare for all? Give me a break. Okay. $45 billion for Medicaid rate equalization. For this strange idea that if you're treating poor people, you should be paid the same as if you're treating rich people. I'm being sarcastic. $27 billion for additional government administration. Because yeah, we're going to have a bigger system. You know, you're going to have to be paying some of that. $112 billion for assumption of Medicare premiums. That's a policy decision. I assumed, and this doesn't have to be, I assumed that nobody would pay premiums, including the elderly. The elderly are big winners on improved Medicare for all, because they get all the benefits of complete comprehensive coverage, much more than what you get now under Medicare, with all its limits. And they wanted to pay premiums, which they now have to pay. And then, $67 billion for covering the uninsured. So notice, doctors are going to get a lot more money. They're going to get the $45 billion from Medicaid rate equalization. They're going to get more work. Where are they going to find the time to do all that extra work? They're not going to be filling out electronic health records. They're not going to be calling insurance companies. Doctors now spend close to 10% of their time processing information for the health insurance industry. totally wasted time. This isn't we're not talking about processing information so they can keep up with their patients, or they can share information with specialists, or with labs. No, this is just processing information for billing purposes. They're not going to be doing that. There will be time that they can devote to their patients. Where are we going to get all the time for the uninsured and for people who will now be able to go to the doctor? Because doctors won't be wasting their time serving the health insurance industry. How would it work? Choose your doctor, go to your doctor, call and make an appointment. Or, hey, go online. My doctor, I gotta say, Epic does this. I can now make appointments online. I can see her calendar, her schedule, and I can find a good time. I really like that. So, I mean, I dump on Epic. Yeah, hey, I dump on Mass General and Partners. But when I needed a second opinion on some cervical procedure, yeah, we went to Mass General, of course. We went into this building. I was seeing this top guy. And he was wonderful. He was a great doctor. But I went into this building that had just been built. Where's Partners spending all its money? Buying Boston. They're buying the real estate throughout Boston. And then, in this case, they put up this building that, hey, what the hell? It could have been an epic, structure. It was so beautiful and fancy. It's like, okay, that's kind of nice. But really? Is this where we want to be spending our money as a society? I would rather it be spent on patient care. But okay, go to your doctor, no copay, no deductible. Hand your doctor your Medicare card. It will have a chip in it. I don't know if this is how it would be, but if they asked me how to design it, this is what I would do. A chip, just like your bank card. Stick, the receptionist when you're leaving will stick your chip, your card into the reader, will type in the diagnostic code, will type in the treatment code. What the hell, your doctor could do this. And that's it. The Medicare Authority computer will then transfer the money into your doctor's bank account. They hand you your card, you are done. Maybe they hand you your prescription. Maybe they already sent the prescription to the pharmacy. That's usually done electronically nowadays. Yeah. So you just go to the pharmacy, hand them your card, and they hand you your prescription. And you can get the health care you need. That is what we're talking about with improved Medicare for all. And that will be the system for everybody. Not just for the billionaires with concierge care, not just for college students going to the UHS, University Health Service. It will be for everybody. Paying the bill, okay, like I say, if we can pay for the current system, that cost $3.6 trillion in 2019, surely we could pay for a system that costs $3 trillion. This is just one financing plan that I worked out. It relies on payroll taxes. People will say, oh, payroll taxes, they're so regressive. Yeah, they are relatively regressive compared to income taxes. But you know what is really regressive? Poll taxes. And that's what the premiums for health insurance and copays and deductibles are. They are poll taxes paid to private bodies. In my right pocket, you take out money for my private tax, the tax that I pay to a corporation. My left pocket, you take out money that I pay to a government body, public taxes. What I care about is the total. Under the current system, you pay the same amount in your private tax from your right pocket, whether you are rich or poor. The chancellor at the University of Massachusetts, who, by the way, used to live in Lexington, Kentucky, where he was provost, earns over $500,000 a year. I'm not going to talk about what he's worth, but he's okay. I mean, the things I like, things I don't like. Maybe more things I don't like than I like. But he's a university administrator, so, he's better than most. Anyway, $500,000, he pays the same for health insurance as does my department secretary receptionist, who earns like $25,000 a year. Her $25,000 a year doesn't even cover her family health insurance plan. His $500,000 allows him to pay off his health insurance in the first 2 weeks on the job. The $50 copay, he doesn't notice it. The $50 copay for the secretary, oh, she thinks about that a lot. Yeah. We would move from that system of lump sum, flat rate poll taxes paid to private parties to a new system of public taxes that are related to income. There are different ways we can do it. We can do it on the income tax, we can do it on payroll taxes, different ways we can do it. But whatever way we do it, by relating what you pay to your income, middle class and working people will benefit. I mean, the poor don't benefit very much because they're largely covered by Medicaid now, even in Kentucky, where you still have it, the Medicaid expansion. But you get to the middle class, and they get big savings, and then you get to, the $500,000 level. Yeah, well, actually, that's $250,000. No, that is $500,000 level. And to the $1 million level, and $2 million level, yeah, they're losing. And when we talk about percentage losses, if they're losing 6%, that's a lot of dollars. I would say that they could afford it. I'm sure that they would say it's not fair. But that's a political issue. There are other ways we could finance it. We could make it more progressive, so the rich would pay even more. We could make it less progressive. Different ways we can do it. The bottom line, though, is of course we can pay for it. If we can pay for what we do now, we can pay for something that's better and cheaper. Economic benefits, jobs. Yeah, there'll be a lot of jobs lost in the paper-pushing industries, in billing and insurance, in hospital administration, in insurance companies. But the economy as a whole will expand. When people save the money that they're not spending on the insurance premiums, they'll spend the money on something else. So we have a transition problem, but overall, the economy will expand by taking the burden off of business. U.S. companies will be able to export. U.S. companies will invest. U.S. workers will be more productive because they're healthier, stress levels are lower, and also because they'll be able to get a better match between jobs and workers. Just a minute, I'm almost done here. Yeah. Productivity will rise, people will be healthier, and will redistribute income away from the rich towards the rest of us, reversing 50 years of going in the other direction. Why haven't we done it yet? Well, this gives you an idea. Here are the total compensation for the heads in 2017, the heads of the major health insurers. Steve Helmsley at United Health Group, almost 16 million, and you go on. The lowest paid, 7 million. Humana, in 2017, Bruce Broussard, I'm sure he's a nice guy, I'm sure he means well, was paid almost $20 million. What do you think they think of Medicare for All? Massachusetts, 66 people were paid over $1 million by non-profit, non-tax healthcare institutions. I looked up the campaign donations. Here's my colleague at UMass Medical, paid $1.6 million. Oh, he's a nice guy, he really is. And he donates to all the right people. Jim McGovern, my representative in Congress, is a stalwart supporter of improved Medicare for all. He's not worried about losing the campaign contribution that he gets from this guy. Would he make $1.6 million if we had improved Medicare for all? Don't think so. Largest lobbies in Washington, pharmaceuticals, 2019, $170 million. I mean, these people have so much more money than the Medicare for All campaigns. Okay, that's the end. So thank you very much, and I'll take questions.